Welcome to Meet the Researcher, delivered by the Westmead Institute for Medical Research, or WIMR, as you'll hear us refer to ourselves throughout today's presentation. My name is Ivan Power. I'm a director of WIMR and chair of the WIMR Foundation Board. I'd like to begin by acknowledging the traditional custodians of country throughout Australia, where we're coming to you from today, and their connections upon the land on which we gather. I'm on Gadigal land here in Sydney, part of the Eora Nation. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples. WIMR is located in the Westmead Health Precinct, as most of you would know. It unearths groundbreaking and innovative research insights to bring about better diagnostics, treatments, and cures, improving health outcomes for current and for future generations. One of the things that makes WIMR so strong in our research and impact is its translational and multidisciplinary capabilities. Translational in that most WIMR researchers are also active practicing clinicians working in the hospital that's just across the road from us, and making our research very highly practical and applied. It's multidisciplinary because we have a broad spread of different capabilities within our expertise, but we also go very deep into each of those, as you'll see here today. That's the benefit of being co-located at the heart of one of the largest health precincts within the region. And for those of you who don't know, as an aside, WIMR and Westmead more broadly has really been at the forefront of the battle that we're going through at the moment on the public health system, being COVID. It's been involved in almost all aspects of the public health response, whether that's testing, tracing, treatments, or vaccine developments. And so that gives you a bit of an insight as to why that translational and multidisciplinary approach is so important, because you're really at the coalface of the developments that are going on within public health and within the science that we're experiencing at the time. And we're really delighted to James and the broader team for making the time out of their busy schedule today, because as you might gather, Westmead is an incredibly busy place at the moment. We're here as you would know, we're here to celebrate the research of Associate Professor James Chong, and to celebrate World Heart Day, which is coming up next week. I'm delighted to have James with us today. He's an interventional cardiologist at Westmead Hospital itself, and he's head of the Cardiac Regeneration Laboratory at WIMR. His research focus over time has been developing new and effective treatments for repairing and regenerating the heart. He has more than a decade of experience in developing stem cell-based therapies for cardiac regeneration, and he's currently investigating methods for enhancing the regenerative capacity of pluripotent stem cell-derived cardiomyocytes. James is also interested in understanding the mechanisms by which the cardiac matrix impacts heart repair after a heart attack, in particular, the effect of platelet-derived growth factor on cardiac matrix composition and remodeling. And thankfully, James is actually going to tell us quite a bit about what that really means during the course of today's presentation. James is internationally renowned for his research. It's been published in top journals in the field of stem cell biology, including Nature, Nature Communications, Stem Cell Science, and Science Translational Medicine. He secured many millions of dollars in funding, particularly through the NHMRC and the Medical Research Future Fund Investigator Grants, and won a number of accolades for his work, including the very prestigious Fulbright Scholarship. He was named one of the rising stars in cardiovascular research by the New South Wales Minister for Health. And as James will explain to us, really what we're trying to do today is to communicate to you that heart disease can happen to anybody, as you'll see by chatting to one of James's patients today, which we're fortunate to bring to you. But also that through the work of people like James, the incredible new therapies and techniques that we have to deal with heart challenges that we face, really the miracles that are happening, that means that people in generations previously who might have experienced things that either killed them or greatly impaired their life, we can actually deal with. So it really is an optimistic and an exciting time to be working in cardiac. James, over to you. Tell us, you're an incredibly accomplished heart researcher and interventional cardiologist treating patients. Tell us a little bit about how you got started, why you're doing this, and why finding a cure for damaged hearts is so interesting and important to you.
Yeah, Thanks, Ivan, for the very kind introduction and for doing this today. And thanks to everyone who's tuning in via Zoom. It's great to have such a great number of people interested. So thank you. Look, I was interested in cardiology, the practice of treating heart patients pretty early. I was drawn to the acute nature of cardiology, the fact that we can have an impact very quickly if someone's having a heart attack or some of these dangerous heart rhythms. So that drew me into that. And then it was only at the end of my clinical training, as I looked to do a PhD and start my research career, that I was drawn to various other possibilities. And my research interest of heart regeneration and stem cells stems from a deficiency, you might say, of the heart. And that's that the heart is one of the least regenerative organs in the body, together with the brain. So most of our audience will know you cut your skin or you break a bone, you can heal that pretty quickly, but the heart has a harder time to do this. In fact, when I was in medical school, I was taught that once the heart muscle's dead, it can't regenerate itself, and you just have to make do with what was left. We now know that's not exactly true, and the heart has a limited but important capacity for regeneration, and that fascinated me. So it fascinated me that if we can really harness this power, then we can help many patients, particularly with heart failure.
And James, you wear dual hats every day. You know, one of them is a researcher hat, and the other is actually a practicing interventional cardiologist at Westmead Hospital. Now, some of our audience might not be familiar about what an interventional cardiologist is. Tell us a little bit about what you do day to day in that role, and what the common heart issues are that you're actually treating on a day-to-day or week-to-week basis.
So Ivan, as you alluded to in your introduction, that's one of the benefits here at Westmead. There's many people like me who treat patients and find out what's needed for our patients, and then we can come back to WIMR and start research projects or experiments that go investigate those issues. So cardiologist just means treating patients with heart disease. Now, the interventional part means that I do procedures, I do things to people's hearts. For me, that is mainly coronary interventions. So coronary refers to the arteries or the blood vessels that supply the heart with its needed nutrients. We can go in and use a little balloon to open up the damaged or narrowed blood vessels, and then we leave a little metal sleeve called a stent in to hold that artery open. And we can do this amazingly by X-ray guidance, just through a little nick in the wrist or sometimes in the groin. And patients are often fascinated that we've been able to do what we can do just through that little cut. So most of my patients will come in with a heart attack, as you'll hear shortly, and I'll use these procedures to open up the blocked blood vessel to cure their heart attack. Then other patients that I see might have not a heart attack, but the same disease that causes the narrowed blood vessels, and we can use the same technology to open up those arteries. As a general cardiologist as well, I see a number of different other heart issues, but my practice is shaped in that interventional area.
And so, James, if I'm to think about cardiology as being a combination of an electrician and a plumber, that's the right way to think about it. It sounds like you're more on the plumbing side than on the electrician side. Is that fair?
Yeah, that's fair. So I'm the plumber, and the co-director of the Centre for Heart Research here at WIMR, Eddie Kazana, he's the electrician.
Right. Okay. That's good to know, just in case. And mate, if you could paint a picture for us of heart disease in Australia today, the current stats in relation to heart disease, you know, both, and I think there is quite a difference between Australian men and Australian women, if you don't mind.
Yeah. So Heart and vascular disease remains the biggest killer in Australia and around the world, Ivan. That's important because that's despite our massive gains in treatment and prevention, information about heart disease. So we've got this slide that will be coming up. It's from a few years ago now, but the data is still relevant. You can see as the bar comes up that heart disease, or coronary artery disease in particular this is, doesn't manifest usually until people are in their 40s or 50s. And then it increases exponentially. So that in the 70s, etc., cases of coronary artery disease are really quite common. And it's a common misconception that coronary artery disease is really a problem for men only. So as you can see from this graph that you've just shown, women are almost equally as affected, but the onset is just slightly delayed. So the important thing I want to stress is this is a problem for both men and women. Although it happens later, it can happen earlier, and we'll see that shortly.
And James, just quickly, any ideas as to why there is that gap between the ages of kind of 45 into people's 60s or 70s?
Yeah, that's a great question, and in fact we're seeing younger patients present more commonly now, and we're not exactly sure why that is. In fact, I've got a PhD student who's also a cardiologist doing her PhD researching that very important question. So I'm not sure we exactly know, but it's an important question we need to find out.
Right. Okay. And James, people often reference heart failure in different ways, and as we described earlier, maybe it's a combination of the electricals and the plumbing. Could you just actually step us through what heart failure actually is and how bad heart failure can be in its different forms?
Yeah, absolutely. So you can think of the heart as a pump, a simple pump. That's partly what attracted me to cardiology. It's the beautiful simplicity of this organ. So if the heart's primary job is to pump blood around the body, heart failure is when it can't do that essential job. And so if blood's not getting around to the vital organs, if it doesn't go to the brain, it might be so severe that you become unconscious. But if it's still able to maintain enough blood pressure, but not enough to supply all the organs, then you might just get feelings like lethargy, tiredness, and that's a common symptom of heart failure. But then as heart failure progresses, blood can pull into the lungs, it can backlog, and that's a horrible feeling. It causes shortness of breath. Patients often describe a feeling, in its worst cases, a feeling of drowning. And then as the blood pools and backlogs further, the fluid can accumulate in places like the legs and other organs as well. So heart failure is a spectrum. It can start mild, but as it progresses, in its worst form, it's a very sinister prognosis. And as you can see in this slide here, it's been reported that as many as 1 in 2 patients with this severe form of heart failure can die within 1 year of the diagnosis with this condition. Now, I want to stress that's not everyone, that's the severe form, but why this is important is it puts it in a very sinister prognostic category that's worse than many forms of cancers. So I think a lot of people don't quite appreciate how bad it can be, and that if mild heart failure, if not treated properly, there's there's a downward spiral that can progress to this severe form of heart failure.
Right. Well, and we're fortunate today, James, that we've actually got one of your patients who experienced that to actually maybe give people a sense, like a real sense about how that can manifest itself, but also how it can manifest itself in people that you would never expect them to. Jeremiah, who's one of your patients that's joining us, he's very kindly agreed to share his story today. So thank you, Jeremiah. But James, you maybe just want to give Jeremiah a quick introduction as to who he is and how you came across him.
Yeah. Hi, Jeremiah, and thanks again for doing this. I can't remember when it was, Jeremiah, but it was pretty recently. I was on call for intervention. I think it was over a weekend. And I got a call about a patient who the emergency department thought was having a heart attack. Now, Jeremiah wasn't at the emergency department yet. He was in an ambulance, and we've got the technology and the protocols now to so rapidly assess patients that the ambulance transmits the heart tracing directly to the emergency department. They send it to me. They told me his age. Jeremiah's pretty young, and I thought, oh, look, it could be a heart attack, but it's less likely. I got them to send the ECG, and the ECG was quite convincing. But there are other things that can mimic heart attacks, including inflammation of the heart muscle known as myocarditis. I didn't want him to take the risk on it not being a heart attack. So I activated what we call the cath lab. That's where we do these procedures. And so that involves an expert team, including radiographers, nurses, junior doctors. So everyone came so that when Jeremiah was arrived at the hospital, we were basically ready to go, and we whisked him up to the cath lab. And indeed, we did find that Jeremiah had a blocked artery, which was surprising. But thankfully, we were able to unblock it. Well, and I'll let
Jeremiah tell his story. I think maybe even then, James, it's a great segue. Is Jeremiah? Maybe if thanks for taking the time. Your life's changed a lot in recent times as a young, very fit fella, thinking about doing an extraordinary long bike ride throughout the beautiful mountains of New South Wales, and here we are. The next thing you know, you're presented with a whole bunch of doctors standing around. Maybe give your side of things about where you were at, what you were doing, the stage of life that you're at, and then we can join the dots in terms of how the two of you actually came together in the lab.
Sure, I think that's pretty much you've nailed it on the dot there. It did come as a big surprise to me. For me, in lead up to that day, I exercised fairly regularly. I was actually going for a bike ride that very morning. My typical week basically involves a couple of runs a week. I usually go for a bike ride on the weekend. I'll normally do about 10-kilometer run twice a week, and usually aim for about 90 to 100 kilometers on the bike on the weekend. But I guess I was taking it a bit easy that weekend and just settled on 50 kilometers. I guess, that in itself is a big number in any case, but I do exercise fairly regularly. But after I came back from that bike ride, I started to feel quite funny. My chest really started to hurt. At first, I just ignored it. I didn't want to really think too much into it, but it just kept persisting. And then it got to the point where I just needed to lie down, and it was really hard just to even get up. And then I guess the self-confidence in me just kept denying the symptoms and not really trying to think any more into it, but it just kept getting worse and worse. After about 3-4 hours after that bike ride, and the pain still persisting, I decided to check myself into the emergency room, and just to get it checked out. I guess the whole way leading up to that point, I guess I was in a lot of denial as to what it may be, even though I knew what the symptoms were, and I knew that it's usually in connection with something to do with a heart condition or a heart attack. I guess the whole way through, I was really denying it to myself as to what it actually was. Even presenting at the emergency room, the nurse who had a look at me was also downplaying, or probably thinking that it was just a reaction from the bike ride and pushing myself too hard. But as James just said, they did an ECG, ran a few tests, and which presented some really concerning results. And then from that point, James and the team took over.
James, maybe pick up the story then in terms of, you know, you had Jeremiah, now he's in your hands, he's your patient. Where do we go to from here?
So I did that procedure that I mentioned earlier. We used the little balloons to open up the artery and then leave a metal sleeve to stent to open up the artery. Luckily, we didn't have too much damage to the heart because we opened up the artery early. And because of that, Jeremiah does not have the heart failure that I mentioned and hopefully won't. I have hopes and anticipations that, so Jeremiah is young, he's in his late 30s, he has, I don't think he'll mind mentioning he has a couple of kids, you know, and I want him to live his normal life as he would. He'll be on some medications to prevent the further risk. Now we know it, but that he has this risk, but hopefully he'll lead a normal life.
And the reason why he actually, you know, is in that position to be able to recover, if we can, is it largely around the ability of you being able to get extremely quickly, him confronting his demons and saying, this needs treatment, and you being able to then treat very quickly because there wasn't that, you know, downward spiral of issues around the heart and around the blockage that meant that in effect there was atrophy or other aspects going on in the muscle that meant the muscle was actually going to be permanently impaired. So is time a critical factor here?
Absolutely. There's a saying in our business, time is muscle. That's the more that the blood vessel remains closed, the more heart muscle's dying and the greater risk of developing heart failure or dropping dead. You mentioned the electrical system. So if there's an area of heart muscle that is dead or dying, that promotes these dangerous arrhythmias. And you know, it wasn't too long before I started my medical training that they didn't even realize heart attacks were caused by these blocked arteries. So that people, the first thing they knew was that they'd drop dead of a heart attack or have severe heart failure. So we've really come a long way over the last few decades in coming up with ways to open up those arteries.
And Jeremiah, your life today, maybe contrast, you know, where you're at today, where you're at in terms of your recovery, and where it is that you hope that plays itself out over the next kind of, you know, year, 2 years.
I think, you know, like I said before, leading up to the day and then my whole time in treatment and the surgery, I guess there was a lot of denial, and I guess it was a bit of doom and gloom about what my prospects are and what the future has in store for me. But it's been very reassuring. And it's also, I guess, a sense of hope that it isn't all doom and gloom, that there is treatment available, and that there is, from what I can understand, a pretty bright future for me. So I guess that gives me a lot of comfort about what's in store for me over the long term, understanding that I do have to take a host of medication and regular checkups, which I think is, under the circumstances, fairly reasonable. But I think into the future, I do hope to return to a normal way of life again, hoping to get back on the bike. I guess, you know, for me, being able to just live a normal life and spend time with my family is what's important to me.
And Jeremiah, you're a risk manager day to day. With your risk manager hat on, what is it that you might be advising some of our audience today of all ages about your experience and any lessons for them?
Look, I think for me, and it's something I do bring up often in my line of work, being in risk management, that you accept a level of risk just by simply walking out the door. If you didn't want to accept any risk, then you wouldn't really participate in life. You can't, you know, you can't live a life with zero risk. It doesn't really exist. But I always try to weigh up with people when talking about risk versus reward, and that when you take on a bit of risk with an acceptance, there is an element of reward to that. And so there's that balance between the two. So I also talk about the fact that you have to manage your risks and work with it rather than deny it.
Jeremiah, it's just wonderful. It's such a fantastic story. Thank you. And James, when we're when you're thinking about Jeremiah's experience, we were talking actually yesterday about this in the context of, yes, there's these incredible treatments that we have, but also the kind of miracles in the small things that mean that the time and various other aspects have actually been, you know, cut down in terms of that. Maybe just step us through those kind of small miracles that, in addition to the wonderful techniques that you've got, the little things in the health system that mean that Jeremiah has actually had his life saved by these process improvements and other things.
Yeah. So I suppose I mentioned about the time gains. So you know, that was pioneered in Australia, a joint effort with Pramesh Kapoor here and North Shore Hospital as well, about this electronic triage. So, and that was rolled out in the New South Wales ambulance service, and that's now commonplace around Australia. But that was a real advance, and then it's a real team effort. I think there's a real specialised group of team from the paramedics initially in the ambulance to the nurses and the radiographers and the medical staff. So and we've learnt incrementally about how to deal with all these different situations of heart attacks.
And James, I think as we'll get to in just a moment, I think one of the other things, and Westmead and WIMR more broadly is certainly going very deep down this path, is the ability to really personalise the treatment to, firstly, the patient and the kind of, you know, the patient that is at hand, and also the circumstances in which that patient finds itself in terms of the condition that they actually have. I expect that if the generation before us had come to the Westmead emergency room, you wouldn't have been able to make so many kind of, you know, decisions very quickly about, firstly, what was going on, who was Jeremiah and what was the issue, and secondly, what the specific issue was in relation to Jeremiah, this concept of personalised medicine or precision medicine.
Yeah, that's right. And I suppose Jeremiah mentioned he knew that something was wrong with his heart. Quite often previously, patients didn't know that was symptoms for heart pain. So that's been important, patient education as well.
And so, James, moving on to your project in a little bit more detail, a lot of people would have heard about stem cells in many different contexts, but not really understood what stem cells are and how they work. Can you just give us the layman's guide to stem cells?
Yeah, I'd love to. So for a cell to be characterized as a stem cell, it needs to have two defining traits. The first one is that it can replicate itself. It can divide. That's what you're seeing here in this image. It can clone itself. But the second trait is that it needs to be able to go on to form other different types of cells. So for my interest, it could form heart muscle cells or heart blood cells. So you can see those two defining qualities can be very powerful. So for me, trying to harness that power to cure heart failure, we can take the stem cell and force it to become heart muscle cells. And then the concept is that the heart muscle cells could be used to replace a patient's own damaged heart muscle, and then hopefully cure heart failure. Now, it's important to contrast this to the only currently available treatment for end-stage heart failure, and that's the heart transplant, which has been remarkable for those patients who need it at that end stage. But there's just not enough donor hearts to go around, and there never will be as our patient population ages. So it's important that we do investigate other technologies such as the stem cell derived project.
So James, it sounds like what you're telling us that stem cells are in a more advanced form, that they're kind of a bit like chameleons, in that they take on that they can very quickly adapt and take on the what they're surrounded with, and you can mold them into new things. Is that a fair kind of way to think about it?
Yeah, it is. The body has learned to as it matures, it uses the stem cells to go and form any other different type of cell. So there's different types of stem cells. So there's adult stem cells, and they exist in the organs of fully matured individuals. The best known is the bone marrow stem cell, but they're limited. Bone marrow stem cells can only form cells within that, we call them that lineage, let's say, cells related to the blood. And most people will know that we use that very commonly now to cure blood cancers after the bone marrow is ablated and then repopulated with these healthy new stem cells. But adult stem cells can't form heart muscle, let's say. So we need another type of stem cell known as a pluripotent stem cell. So these stem cells really have the ability to become any different cell in the body, which is really fascinating. But we've learned from developmental biology how to trick the cells to become the cells that we want. And so for me, we trick it to become heart muscle cells. And that's what you're seeing now in the video on the screen. This is a video, and you're seeing what we would see as we're looking down the microscope. This is stem cell made heart muscle, and the heart muscle is beating of its own will in the dish in the laboratory. So it's a very powerful technology, and in our lab and with our collaborators in the University of Queensland, we're literally making heart muscle cells by the billions for this project.
James, how is your research project actually going to change the way we treat heart disease and heart failure? What's the premise of using stem cells to achieve some of these gains, and what change do you really hope to bring about?
Yeah. It's early days. I just make that clear. And the concept's simple. I referred to the heart as a pump, and this pump supplies blood around the body. So when the heart fails, it can be from a heart attack, as you're seeing here, by a clogged artery, and then there's a lack of blood flow going to that area of the heart, and that area of heart muscle dies. So we want to try and replace that damaged heart muscle by using stem cell derived heart muscle, injecting it back into the heart, and then the stem cell derived heart muscle can couple and integrate with the remaining healthy heart of the patient and restore that pump function again. And I mean, hopefully our idea is to treat heart failure, to end stage heart failure, to become one day a cure, hopefully.
And James, what's been achieved to this point in terms of where are you at in terms of that project? Maybe step us through, in its entirety, where you're at, the process, where you're at, and what's to come.
For the field, we've come a long way. So this technology has been the culmination of scientists working diligently over decades. That technology to reprogram an adult skin cell into becoming a pluripotent stem cell. That one, its discoverer Shinya Yamanaka, the Nobel Prize in Medicine, about 2012, I think it was. And so it's come a long way in the field, so that we're now at the stage to harness this stem cells' power. And I was fortunate to be able to work with one of the leaders in this field, Professor Chuck Murray in Seattle in the USA. And then when I returned to Westmead and started my own lab here, this stem cell derived heart muscle was going to be an important part of the program, not the only part of the program, but an important part. So we've been refining ways to improve the heart muscle change. We've worked towards the safety. One of the things I found in Seattle was that there can be dangerous heart rhythm abnormalities after we transplant these heart muscle cells. And so a lot of our efforts on this project, and it's been championed by a PhD student who's also a cardiologist, Nesh Selvakumar, we've found ways to suppress those heart rhythm abnormalities, and we're really excited that we think we've got a handle on why they occur, and then therefore how we might be able to abolish it. So we're at the stages almost to take this to the clinical arena.
And you probably get asked this a lot, James, and it might be difficult to answer, but when do you think we might actually be seeing this in human trials? You know, I know that unlike some other areas, that very often, you know, areas like this, it actually moves at quite a glacial pace. How do you think, when do you think you might be able to deploy this technology?
Yeah, it's a very difficult question because it's so dependent on many different factors. Before we take a cutting edge therapy into the testing into humans, we really want to be sure about the safety. So, and that can be derailed in a number of places. And usually I'd hate that question, Ivan, but recently we've been very generously supported by the government to take this project into the clinical stages. And if everything goes well, we hope to enroll patients in a small safety trial using this technology. So within 5 years, which is very fast. And I emphasize that, you know, there's a lot of things that need to go right to make that timeline, but we're cautiously optimistic. I mean, part of that is that we have such a great setup now. We've developed the tools and the model to further investigate aspects for safety. And that's where this campaign by the WIMR Foundation and the National Stem Cell Foundation also comes in, because a therapy, even once it's taken into the clinic at the early stages, it's never at its final iteration. There's always constant refinement, improvement that is required, and that needs to happen often a lot at the bench side.
And James, from your perspective, what is it that excites you the most about the research? What kind of really gets you out of bed, and what is it that you really, you know, that really gets you excited about what you're doing every day?
Yeah, I mean, it's the patients. It honestly is. You know, it's that we can see problems that the patients have that we're treating, and the limitations of our current therapies, and then we can go back and try and bridge that gap. So that's really exciting. And then also finding out more, that quest for knowledge. I mentioned it wasn't that long ago, we didn't even know heart attacks were caused by clots to the blood vessels. But there's so much more we don't know. And here at WIMR, where we're trying to push the boundaries of knowledge that will lead into new and further discoveries. That's what excites me.
And James, just before I ask you, a couple more questions, I've got just a reminder to people that we have a Q&A function on Zoom. It's not very often you get the attention of an interventional cardiologist. So if you have any questions you'd like to ask James about, we'll leave it to cardiological matters at this moment. If you want to ask James any questions, please log, and more than happy to ask some of these questions. James, there's been unbelievable developments through this public health challenge that we're experiencing at the moment that have really fundamentally changed the way that we as a health system are actually looking at patients, and also the technologies that we're actually using within patients. When you're looking at that, what's the thing that's happened over the past 18 months that makes you look with great optimism towards the future?
So you're talking about COVID-19?
Just more broadly, in terms of whether there's whether it's a public health thing, whether it's technology, whether it's people's behaviours, whether it's actually specific elements of how it is that we can be delivering drugs, or the technology that we're using, or even possibly approvals of some of these.
So it's hard over that time frame. It's hard not to think about COVID-19, obviously. So. And it's really been fascinating how fast the world has been able to mobilize and get technologies that, yes, existed but weren't quite ready, but to fast track that into patients and to roll it out to millions around the world. I mean, that's just amazing. And messaging, the importance of public health messaging, that's been clear over the last 18 months. It's very important. Over the last 18 months, if I look at a slightly negative effect, it's that we see a lot more patients not coming to the clinic, understandably, especially during lockdowns. But I want to stress that it's really important for people to look after their health, not just their heart, obviously everything else. After the lockdown last year, we saw a slight rebound after that, where there were a lot of things that were perhaps being left whilst they were locked down, manifesting later. So those things come to mind.
And James, in terms of actually, while we're talking about COVID, the impact of COVID, the risks posed to the human heart by COVID, and the impact of of COVID upon the heart in patients that you might be seeing actually presenting at Westmead.
So fortunately, we haven't seen too much heart-related disease from COVID-19. There's a lot of patients with COVID-19 in the wards and presenting to Westmead, but we're fortunate not to have had too much with the heart. We know, though, from examples from around Australia and more commonly around the world, in other places around the world, that the virus can actually infect the heart muscle too. In fact, I was wondering whether it might be COVID related, but for Jeremiah, even it turned out not to be. But that inflammation of the heart muscle, it's called myocarditis. So that can happen with COVID.
Extraordinary stuff, James, and really encouraging to hear that we actually haven't experienced as much of this in Australia, but fortunate once again that we are able to borrow all of the experience from overseas, and importantly that's being able to be communicated so rapidly around the world, which I think is one of the things that, as you're saying, and you said earlier, time is muscle when it comes to the heart. And so obviously the ability of cardiologists globally to be able to share this information just means that we end up as a global population in significantly better shape to deal with some of these challenges and to treat them, and therefore to give so many extra years of useful life to people, in what used to be, such an incredibly crippling disease. I've got a couple of questions that have come through, and please continue to log them, because James, as you can tell, is very open and honest on this stuff. Madison asks us who the big players are in cell therapies for cardiac regeneration globally. Any thoughts?
Yeah. So I'll speak to the heart because that's my area. So there's a few big players. My mentor, Chuck Murray in Seattle, he's as a world-leading program. There's some clinical trials that have already started. Wolfram Zimmermann in Germany has started recruiting for a clinical trial where he uses the heart muscle, stem cell-derived heart muscle, within a bioengineered scaffold. And he's recruiting patients there. There's 2 trials in Japan where the induced pluripotent stem cell technology was founded. They're recruiting for these stem cell-derived cardiomyocytes. There's a big group in Canada as well. So it's an incredibly exciting time. And within our group, we're hoping that we can bring Australia along at the forefront of this technology, which really might be a game changer.
And James, Ed asks us on a kind of coming back to the treatments, he says, presumably it's easier to repair a slightly damaged heart than a severely damaged one. What do you think is the maximum level of damage that could be sustained and still be able to be treated successfully, if it's possible to quantify?
Yeah, that's a really great question. And I don't think we can answer that yet. As mentioned, when you're looking at a novel therapy, first you look at safety. So you have a small study where you just scrutinize safety, but then it's further trials after that where you tease out which patients would benefit better, what dosages might change, a host of different questions. So it's a great question, but one I don't think we can answer yet.
Well, maybe to come at it another way, if we compare ourselves to a generation ago, so 20 years ago, how far further have we come in terms of significant, in terms of the level of damage that we are able to repair? Have we made leaps and bounds in terms of the amount of damage that we are able to repair relative to 20 years ago?
We've come quite a fair way. So a lot of the drugs that we use have alleviated the symptoms of heart failure, and it's prevented that gradual decline that I mentioned, where you go from mild heart failure to that severe stages. So we can treat patients and keep them quite stable for a while. We haven't had that incremental benefit where there's a severe heart failure already, either from a massive heart attack or an undiagnosed condition that had not been treated for some time. And it's those patients that we really need new solutions for.
Right. Maureen asks us, what are the preventions? Obviously, you're working through cures. What are the preventions here? Are there any antecedents? Are there any factors, whether it's individual or lifestyle factors, that increases the success of your interventions, or hopefully preventing them not being required to be used at all?
Yeah, absolutely. There's lots. So, I mean, we look at heart attacks, which is one of the major causes of heart failure and of mortality. And most people know this. So it's a healthy diet, it's exercise, it's not smoking, it's controlling your blood pressure, you know, all of those things. And I don't want any listeners to hear Jeremiah's story and say, look, you know, this guy can exercise and look after himself and he still has a heart attack, so I won't. Because I do have patients who take that attitude. But I think in Jeremiah's case, it's because he was well conditioned and healthy that he was able to compensate quite well.
We've got another question, James, about any, is cardiovascular disease a lifestyle issue or is it down to genetics?
Yeah, it's a combination. There are clearly genetic factors. So if there's a family history of heart disease in the family, then there's a higher chance. But there's a lot of lifestyle changes as well. So like I mentioned, you know, smoking, damage, a lack of exercise, a poor diet, they can all contribute. So it's a combination of the two.
James, Tony asks us, how is stem cell growth controlled after implantation?
Yeah, another really excellent question. So, and this is what researchers have spent decades trying to work out and study. So as mentioned, my area is trying to force it down the heart muscle lineage. But other researchers are looking to push stem cells down to create new brain tissue or new islet cells for diabetes. So that power can be harnessed for other things. And it's at that early stages that you control it. Once the fate has been changed or chosen for the stem cell, and then it becomes that differentiated cell. And once it's differentiated, it loses its stem cell ability. So you have to get it early and differentiate it to the right cell type.
And James, are there risks associated with stem cell therapy?
Absolutely. I mean, there can be, which is why it's very important to do the right controlled studies. You know, there was a little while where people were using adult stem cells predominantly around the world in a more uncontrolled way. There were practitioners just popping up and putting cells that they claimed were stem cells, often they weren't even, into different organs for different things. And that comes with a lot of risk from the procedure itself, from the cell type. So all of these things need to be done in a very careful and controlled way.
Tony also asks us about, you know, talking earlier about getting insights from across the world. do researchers like you share your findings so that time and money is used effectively and efficiently? And how might that have changed actually over the last 20 years?
Yes, we do. We share that. That's one great thing about working in science. You're part of a global community, and you really do feel that when you're working together. Obviously now we can't travel around, but that there's international meetings where we talk about our work. And then, you know, we publish. So we write our findings up in scientific manuscripts, articles, and that's available to everywhere around the world. And the internet's changed things. So, you know, when I was studying medicine, you used to go to the library and photocopy these journals, and it was a little limited. Now you can instantly have it from all manner of journals, just download it. So that spread of information occurs very rapidly around the world.
Just a last question, James, from one of our listeners who's actually a PhD student at the University of Sydney, who's looking at stuff around biodegradable nanocomposites for stent fabrication. He's asked whether he can get in touch. I know that your details are on the WIMR website, so maybe that's something that he should look on the WIMR website and maybe get in touch if that's something that that would be useful to you.
Yeah, absolutely. Shoot me an email. Always happy to start collaborative discussions. That's the way science works, and so happy to get in touch.
Fantastic. Well, James, you know, we're coming up now to the end of our session. Any last thoughts that you'd like to leave our audience with?
Yeah, just to thank you, Ivan, and everyone listening for tuning in. So the main thing I wanted to show, and why thanks to Jeremiah, obviously, the main thing that I wanted to invite him on for is to show that, you know, heart disease can happen to almost anyone, and to be aware of those symptoms and signs, and to seek help if needed. And then the other thing is that there's fantastic new therapies, not just here at WIMR, obviously, but happening around the world. And we need people to come into this, to have careers in science, to develop new therapies.
James, that's fantastic. Thank you. And thanks to everyone else who's joined us today to listen to James's excellent talk. As many of you know, next week is World Heart Day, and WIMR has quite a large campaign underway in order to support that and to support research like James is doing. There's many ways that you can get involved in actually assisting WIMR in terms of our research. It's simple things like actually sharing some of the insights that you got out of today's session. It's actually following us on social media and sometimes sharing those insights as well. In addition to that, it's coming to events like this. And in many cases as well, it's actually, you know, being able to support financially, which we're always generous of, always grateful for. We've got an initiative at the moment around World Heart Day, which, as I said, is in a week's time, next Wednesday, where any donation that you're able to make for World Heart Day through September will be instantly matched by the National Stem Cell Foundation of Australia. There's the link on screen there now, but if you go to our website or you're looking on any of our socials, you'll see links to that as well. We'd be exceptionally grateful for those who are able to support us through that and to support James's research. There's so many other fantastic stories as well coming from WIMR in terms of the miracles that are actually going on in our institute. And yes, there's a lot going on with COVID, but through COVID, we've actually got people like James and many of his colleagues who are continuing to work in the background these wonderful miracles on a day-to-day basis. And like he describes, the progress that you see on a day-to-day basis might not be great, but the way that this compounds over time and the dividend that we in society get is absolutely extraordinary. And in Australia, we're not always as supportive as some other countries in terms of our support for medical research. So please, if there's any way, in any of those ways, just even in terms of sharing this story and sharing some of those insights, we'd be incredibly grateful. We thank everyone for their support, and we hope you have a really, really lovely day. Thank you, James.
Thanks, Ivan. Thanks, everyone. Thanks, John.